In regards to how we treat patients with hepatocellular carcinoma, specifically the case that we have here in front of us, this is a patient with advanced disease, BCLC stage C, and therefore the standard is to start with systemic therapy. Currently, we have two standard approved, FDA approved options. One is sorafenib, which has been approved for about over 10 years at the moment. This is again the oral multi-targeted kinase inhibitor, where we know that it was found to be superior to placebo in 2 international trials. Then the REFLECT trial evaluated lenvatinib in a non-inferiority study compared to sorafenib and showed that lenvatinib met the non-inferiority criteria. So lenvatinib became a second option for first-line treatment of advanced HCC. As a reminder, lenvatinib is another oral multi-targeted tyrosine kinase inhibitor. But in addition to targeting the VEGF, the vascular endothelial growth factor axis, and the MAP kinase pathway, that's what sorafenib does. Lenvatinib targets the VEGF receptors more potently, but it also targets the fibroblast growth factor receptor pathway, which is thought to play an important role in resistance to anti-VEGF therapy. Now, the atezolizumab-bevacizumab combination, which this patient was treated with, is an emerging combination based on phase 3 data that has been presented in the IMbrave150 clinical trial, which is a phase 3 study. This combination is under consideration at the FDA for approval, but it's not currently approved at the time of this recording. The IMbrave trial compared the combination of atezolizumab and bevacizumab versus sorafenib. Atezolizumab is an anti-PD-L1 antibody. Bevacizumab is an anti-VEGF antibody. There is ample rationale for this combination because we know that targeting the PD-1 or PD-L1 axis has activity in HCC. But then we know that targeting VEGF can modulate the immune microenvironment to potentiate the PD-1 response. We know the anti-VEGF therapy can lower some of the immune suppressive cells in the immune microenvironment. So they lower myeloid-derived suppressor cells as well as T regulatory lymphocytes. They also, anti-VEGF therapy may contribute to the recruitment of cytotoxic T cells into the tumor and upregulate PD-L1 expression. So that is great rationale for this combination. We know this combination had shown promising activity in the phase 1b setting, which led to the phase 3 trial. So let's talk about the phase 3 study. The phase 3 study again compared atezolizumab-bevacizumab to sorafenib and was a positive trial. It showed a hazard ratio of 0.58 with a 42% reduction in the risk of death. So the hazard ratio of 0.58 was for the primary endpoint of median overall survival. Similarly, there was a significant improvement in median progression-free survival. Of note that the median overall survival for the sorafenib arm was 13 months. The median overall survival for the atezolizumab-bevacizumab combination had not been reached yet at the time of the presentation. So we are awaiting further follow-up on that. The response rate with the atezolizumab-bevacizumab combination was in the low 30% range compared to, I think, about 12% with sorafenib. So sorafenib, again, performed better than historically known in this trial, but nonetheless, the combination was superior to sorafenib alone. So this is likely to become, again, an important first-line option as it gets regulatory approval potentially in the near future. What is the rationale in this situation for choosing the combination versus a TKI, meaning sorafenib or lenvatinib? As we discussed, the atezolizumab-bevacizumab combination was shown to be superior to sorafenib with all endpoints being positive. So therefore, for the right patient, this combination would be the go-to option once approved and available because it is superior to the TKI. Again, some words of caution. This combination was evaluated in patients with Child-Pugh A cirrhosis. All patients must have had an endoscopy within 6 months prior to enrollment, and if they had varices, those must have been treated according to institutional standard. So the patient must meet those 2 criteria. I would be cautious about using this combination in patients with more advanced liver cirrhosis, especially Child-Pugh-B and above, until we know that it would be safe, because as the Child-Pugh score is higher, there's a higher chance of liver cirrhosis and a higher chance of more advanced portal hypertension and bleeding. Lastly, one has to keep in mind the contraindication to atezolizumab and bevacizumab. So active autoimmune disease would be a contraindication. Similarly, recent bleeding in the past 6 months or recent arterial thrombotic events would be a contraindication to bevacizumab. In those situations, one would probably still choose to go with the TKI instead of the combination of atezolizumab and bevacizumab.